Total anomalous pulmonary venous connection TAPVC, also referred to as TAPVR for return, is universally categorized using the Darling classification, which groups the anomaly based on the anatomical site where the pulmonary veins drain into the systemic venous circulation. Because the pulmonary veins fail to connect to the left atrium, oxygenated blood mixes entirely in the right atrium. Regardless of the type, an obligatory right-to-left shunt, an unrestrictive ASD or PFO, is required to sustain life. Four anatomical types are there. Type 1, supracardiac, most common, about 50%. The four pulmonary veins gather into a common posterior venous confluence behind the left atrium. Blood drains upwards from this confluence into an ascending vertical vein, a remnant of the embryonic left superior vena cava, which empties into the left brachiocephalic innominate vein, flows into the right superior vena cava, and finally enters the right atrium. This creates the classic widened mediastinum known as the snowman sign or figure of 8 on a frontal chest X-ray in older infants. Type 2, cardiac, 20 to 25%. The pulmonary veins drain directly into the heart itself, bypassing the systemic veins entirely. The posterior confluence connects directly to the coronary sinus, which becomes massively dilated, or less commonly opens directly into the posterior wall of the right atrium. This type is usually unobstructed and carries the most straightforward surgical repair, unroofing the coronary sinus into the left atrium and baffling the ASD. Type 3, infracardiac subdiaphragmatic, about 20%. The pulmonary veins drain downward below the diaphragm. The confluence empties into a descending vertical vein that passes through the esophageal hiatus of the diaphragm. It typically connects to the portal vein, the ductus venosus, the hepatic veins, or the inferior vena cava. This is a true pediatric cardiac emergency. It is almost universally obstructed because the vertical vein is squeezed as it passes through the diaphragm, or the drainage gets choked off when the ductus venosus naturally closes postnatally. Neonates present rapidly with profound cyanosis, severe pulmonary edema, and cardiogenic shock. Type 4, mixed, around 5 to 10%, a combination of two or more of the above drainage pathways. The most frequent combination involves the left pulmonary